So today we're going to talk about a basic approach to EKG interpretation. In med school, they teach us that the best way to read an EKG is to start with the rate, rhythm, and axis. We're taught to remember the exact measurements for the different intervals. And all of this is great when you're just starting off, but when you're looking at an EKG in the middle of the night and your brain is starting to fade a little, you really want to look at the EKG from a different perspective. Instead of honing in on a lot of the nitty-gritty, what you really want to focus on is the bigger picture. And that's what we'll talk about today, is an alternative approach to EKG interpretation that actually allows you to look at the bigger picture. The big picture being, why did I order this EKG? What am I specifically looking for? And with that answer, what am I going to do with the information? How am I going to intervene on this patient? What are the things I cannot miss? So let's get started. The first reason you may get an EKG is because your nurse may call you and tell you that your patient's heart rate is too fast. You'll want to get the EKG to figure out whether or not the patient's heart rate is regular or irregular, if it's a narrow or wide complex tachycardia. But ultimately, the thing that you're most worried about is whether or not you're going to need to cardiovert your patient because they're in an unstable rhythm. The second reason why you may get called by your nurse is because your patient's heart rate is too slow. And really what you're worried about is whether or not the patient is going into a heart block. And the third question that you'll have is whether or not your patient is having a heart attack and you need to call a cardiologist to take the patient to the cath lab. So how do you know if your patient's actually having a heart attack? Well, in order to figure that out, you'll have to understand how the EKG will change once you have 100% occlusion of a coronary artery. So let's go ahead and start with a basic EKG. The first thing that you'll see when there's 100% occlusion of a coronary artery are peak T waves. And these are different from the peak T waves that you see in hyperkalemia, in that they're a little bit more broad-based, versus in the hyperkalemia one, they're pretty narrow-based, and if you tried to sit on that, it would hurt. The next thing you'll start seeing are your ST segment elevations into your classic tombstone appearance. After that, the ST segments will flatten, and you'll get flattened T waves until you finally get your T wave inversions. As everything is flattening out, your Q wave is getting bigger and your R wave is getting smaller until all you have is a massive Q wave. So in the completed MI, this is what your EKG will look like. So once all the damage is done, if there has been no intervention, what you'll see is a P wave, a massive Q wave, and a T wave inversion, although sometimes the T wave can actually be upright as well. And this is what a completed MI will look like on your EKG. So again, what you're looking for are 1, peak T waves, 2, ST elevations, and here I'll usually include depressions, which is what you'll see in subendocardial injury or NSTEMIs. 3 is flattened T waves or T wave inversions. And finally 4 would be Q waves. So when people talk about dynamic EKG changes, this is what they're talking about, this progression. So now that you have your 3 questions, your approach to the EKG should be as follows. Look at the rhythm strip to answer questions 1 and questions 2. Really spend time there figuring out if the patient is having significant tachycardia, bradycardia, are they in an irregular rhythm that's narrow or wide, or are they in second degree type 2 heart block or third degree heart block. So really take your time and actually look at the rhythm strips that are generally printed either at the top or at the bottom of your EKG. After that, look at each of the EKG leads in a geographical distribution and ask yourself these 4 questions. Is my patient having peak T waves? Are there evidence of ST elevations or depressions? Are the T waves now flattened or inverted? Are there Q waves? And only after you've answered these 4 questions for each geographical distribution should you move on to the next one. As a review, we can go over what the geographical distributions are for your EKG leads. Your lateral leads will be 1, AVL, and V5 and V6. Your inferior leads will be 2, 3, and AVF. And finally, your anterior leads will be V1 to V4. So the general idea is if you see some subtle changes in your EKG, such as maybe peak T waves or new T wave inversions, what you'd want to do is immediately check for an old EKG and see if these are in fact the same as a prior EKG or if they are in fact new. If they are new, you'll want to get a repeat EKG as soon as possible. So go ahead and put the order in. It'll probably take your nurses 20 minutes to get the machine set up and to finally print you out a copy, and hopefully in that time you'll start seeing some dynamic changes if they're in fact having an acute STEMI. Don't wait the 4 hours that we usually have as a standing order when we're ruling people out for a STEMI. So now that we've gone over all of this, let's actually go over some examples and apply these principles. So here's our first EKG, and let's start with our first 2 questions, which is it too fast or is it too slow? So to figure that out, let's not look up here, but rather let's start with our rhythm strips at the bottom of the screen. As we look through this EKG, we can see that it's in fact a normal rate. The QRS complexes are narrow. It looks pretty regular. There's definitely like a P before every QRS. So it doesn't look like this patient gets any electricity. Now let's attack the big question, which is whether or not our patient is having an acute MI. So the questions we're going to ask are if our patient has peak T waves, if there is evidence of ST elevations or depressions, if we see flat or T wave inversions, and finally, if there are any Q waves. And we're going to do that in a geographical distribution. So we're going to look at 1 and AVL first and ask ourselves, do we see any peak T waves? Do we see any ST elevations or depressions? Do we see any flat or T wave inversions? Do we see any Q waves? So looking at these leads, you'll see that AVL does in fact have a T wave inversion, but 1 is in fact fine, so it's only in 1 lead. We'll then look at our inferior leads, 2, 3, AVF. And again, we're going to ask ourselves, do we see any peak T waves? Do we see ST elevations or depressions? Are there any flatten or T wave inversions? Do we see any Q waves? And what we see here are isolated Q waves in lead 3. Again, since this is only in 1 lead and isn't in 2 contiguous leads, we can not be as concerned about it. Now we'll look at our anterior leads, which are V1 through V4. And again, we're going to run through the same exercise of whether or not we see peak T waves, ST elevations, depressions, flattened T wave inversions, and Q waves. And in these leads, we don't see anything. Lastly, we'll continue to evaluate the lateral leads by looking at V5 and V6. And again, we don't see anything that would be concerning for an acute MI. So in summary, for this EKG, we see that it's not too fast or too slow. The patient doesn't need any electricity. And looking through all the leads in a geographical distribution, we don't see any evidence of any ischemic changes that require activation of a cath lab. But by spending your time looking at the EKG this way, you'll really be able to make sure you don't miss anything. For example, in this EKG, we did identify the Q waves in lead 3 and the T wave inversions in AVL. If we were really wanting to be thorough with this, we could check an old EKG and make sure that these are not new changes. Or we could also get a repeat EKG to ensure that there are no further dynamic EKG changes. Here's the second EKG that we'll look at. We're going to start the same way and ask our same first two questions, which is the rate too fast or is it too slow? So to do that, again, we're not going to be looking at the top left corner of our EKG, but rather we're going to start with our rhythm strip. As we look through this EKG, we can see that the rate isn't too fast and isn't too slow. We see that it's a narrow complex QRS, and we also see that there are P waves before every QRS complex. So this is another patient that won't be getting any electricity. And now we move on to the big question. Is this patient having an acute MI? For this, we're going to ask our same questions. Do we see any evidence of peak T waves? Are there any ST elevations or depressions? Does the patient have any flatten or T wave inversions? And finally, do we see any Q waves? So we'll start by looking at leads 1 and AVL. In these leads, I don't see any peak T waves, ST elevations, or depressions, but I definitely see what look like flattened T waves. Next, I'll look at my inferior leads, 2, 3, and AVF. And here again, I don't see any peak T waves, I don't see any significant ST elevations or depressions, but I definitely see what look like flattened or T wave inversions in 2, 3, and even AVF. It looks like there are definitely some T wave inversions there. Now we'll look at the anterior leads, which are V1 through V4. At this time, I don't see any peak T waves, but I definitely see what looks like ST elevations in V2, V3, and even V4. And finally, completing our lateral leads, we'll look at V5 and V6. Here we don't see any peak T waves, but again, it looks like there may be some subtle ST elevations in V5 and maybe flattened or T wave inversions in V6. So looking at this EKG, alarms should be going off in your head. Because of how you've diligently gone through each of the leads in a geographical distribution, you've identified that there are in fact ST elevations in the anterior leads. And as a result, this is definitely a patient that if you are unable to find an old EKG on them, you should be getting in touch with your cath lab and potentially activating a Stemi. To wrap up this lecture, we'll just mention Stemi Equivalence. Now, we're not going to go over all of them in detail here in this lecture. We'll have another lecture that you can watch where we will go over them. For posterior MIs, you want to look for deep ST depressions in the anterior leads. The next one would be ST elevations in AVR, which is consistent with occlusion or near occlusion of the left main artery. The third one would be De Winter's T waves. Number 4 is Garbosa's criteria, which you'll use on patients who have left bundle branch blocks. And finally, number 5 would be Welland's syndrome. Wickham.org has a great article on this. So if you go there and you just search Stemi Equivalence, it'll pull up that article for you. And it has great examples and great descriptions of each of these Stemi equivalents. The last thing that we'll talk about will be what your differential diagnosis is for ST elevations. So not all ST elevations are a STEMI, or myocardial infarction. Other causes of ST elevations would be a left bundle branch block, benign early repull, or J-point elevation, pericarditis, and finally, a left ventricular aneurysm. So hopefully this approach will help you when it's the middle of the night or you're by yourself and you're trying to figure out whether or not you need to act on someone's EKG. It's meant to be just a practical guide. There's a lot in the true art of reading an EKG thoroughly, but we hope that this at least helps you make sure that you don't miss anything that is truly life-threatening and will at least launch you on that path to really learning how to read EKGs well.